Welcome. I will be speaking about clinical characteristics of addictive disorders, which is actually quite a wide topic, but I will try my best so as to wrap it up. Now, for substance-related and addictive disorders, we can speak about 10 separate classes of drugs: alcohol, caffeine, cannabinoids, hallucinogens, inhalants, opioids, sedatives, hypnotics, anxiolytics, stimulants, which is actually the biggest trouble of the era, tobacco, and other or unknown substances. Now, looking at the addictive disorders, we use also the term behavioral addictions in the literature. In DSM-5, it's only gambling disorder that we have, but other potential behavioral addictions, internet addiction, sex addiction, exercise addiction, shopping addiction, not included in diagnostic criteria, but DSM-6, they also will probably be a part of a disorder. With regards to substance use disorders, the essential feature is the continued use despite significant substance-related problems. And there are changes in brain circuits, they may persist, which exhibited in repeated relapses and intense drug cravings. Criteria include impaired control, social impairment, risky use, and pharmacological symptoms such as withdrawal and tolerance, which are the main features in diagnostic criteria. And there are 11 diagnostic criteria, and 2 must be the case that lasts for 12 months. What are those? Substances often taken in larger amounts or over a longer period of time than intended. A persistent desire or unsuccessful efforts to cut down on control use, a great deal of time spent in activities necessary to obtain the substances, and craving or strong desire or urge to use. Recurrent use resulting in failure to fulfill major role obligations at work, school, or home. Continued use despite having persistent or recurrent social interpersonal problems. Important social, occupational, or recreational activities given up or reduced because of use. Recurrent use in situations which is physically hazardous. Used in continuous despite knowledge of doing it and having physical tolerance and withdrawal. Intolerance, for example, the need for markedly increased amounts of substances to achieve intoxication or desired effect, or markedly diminished effect with continued use of the same amount. Therefore, increasing. This is actually the tolerance. Withdrawal, a characteristic syndrome or used to relieve or avoid withdrawal, some certain symptoms. And this actually can be at different levels for different substances, which I will speak about later. So, 11 diagnostic criteria that we have. For at least 2 of them, if lasts for more than 12 months, then we can put the diagnosis of substances use disorder. Alcohol-related disorders. According to the studies, 12% of prevalence in males and 4.6 in females. Significantly drops after age 65. What is important is, related to depression, there is a lifetime risk of major depressive disorders by 40%, and there are certain neurocognitive disorders. Alcohol intoxication includes one or more symptoms of slurred speech, incoordination, unsteady gait, nystagmus, attention, memory impairment, and stupor coma. So, if one or more of symptoms, then we can speak about alcohol intoxication. How about alcohol withdrawal? Autonomic hyperactivity, sweating or pulse over 100, increased hand tremor, insomnia, nausea or vomiting, transient visual, tactile, auditory hallucinations, psychomotor agitation, anxiety, and seizures. If 2 or more of the following after cessation of alcohol use, then we can speak about alcohol withdrawal. How about caffeine-related disorders? Actually, according to the studies performed, especially in children and adults, more than 85% of them consume caffeine regularly. If we consider this as a substances or as a substances, it is the most widely used one. There is nothing about caffeine use disorder in DSM-5, but it is mostly caffeine tolerance and withdrawal, especially among the young people and adolescents. There is actually a significant use of increase in energy drinks. At the same time, during adulthood and adolescence, oral contraceptives. They, at the same time, decrease elimination of caffeine. Therefore, there is an increased risk of intoxication. How about caffeine intoxication? It must be in excess of 250 mg or more. There is actually intoxication symptoms such as restlessness, nervousness, insomnia, flushed face, diuresis, gastrointestinal disturbance, rambling flow of thought and speech, tachycardia, arrhythmia, psychomotor agitation. If five or more of the following, then we can speak about caffeine intoxication. How about caffeine withdrawal? What are the symptoms that we observe? Following cessation in use within 24 hours, headache, marked fatigue, dysphoric mood, depressed mood, irritability, difficulty concentrating, or flu-like symptoms. If we have three or more of the following, then we can speak about caffeine withdrawal following cessation. How about cannabis-related disorders? It is 3% in adolescents and 1.5% in adults. Again, similar to alcohol, prevalence drops after age 65. It is more common in males than females, and cannabis use disorders have increased over the past decade. It is difficult to distinguish between problem use and non-problematic use. And again, 60% of adolescents also have ADHD. How about cannabis intoxication? Cannabis intoxication, in terms of long use, can lead to psychotic or anxiety disorders, sleep disorders, or delirium. Problematic behavior or psychological changes could occur, like motor coordination, euphoria, anxiety, sensation of slow time. Again, in intoxication, there could be conjunctival injection, red eyes, increased appetite, dry mouth, and tachycardia. Two or more of the following can lead us to cannabis intoxication. How about cannabis withdrawal? After irritability, anxiety, sleep difficulty, decreased appetite or weight loss, depressed mood, and sweating, fever, headache, tremors, these types of physical symptoms. If we have three or more of the following, then we can speak about cannabis withdrawal. Hallucinogen-related disorders. DSM-5 divides it into two: phencyclidine disorders and other hallucinogen disorders. 10 symptoms, including substances abuse, excluding the withdrawal symptoms, also the case for other hallucinogen disorder, use disorder. They are rare, but they can lead to psychotic-induced, bipolar-induced, depressive-induced disorders. Therefore, it is a striking one. How about phencyclidine intoxication? Mainly problematic behavior like impulsivity, agitation, and there could be vertical or horizontal nystagmus, hypertension or tachycardia, ataxia, dysarthria, muscle rigidity, hyperacusis, seizures, or coma. If two or more of the following is the case, we can speak about phencyclidine intoxication. Other hallucinogen intoxication, problem behavior, or psychological changes. Similarly, anxiety, depression, paranoia, and some perceptual changes could be the case, like illusions, hallucinations, realization. Similarly, pupillary dilatation, tachycardia, sweating, blurred vision, tremors, incoordination. These are the certain symptoms. Inhalant-related disorders involves any hydrocarbon-based substances, toxic gases, paints, some glues. There is actually no diagnosis of inhalant withdrawal, and standard drug screens do not, unfortunately, detect inhalants. If we do so, it would be very costly. Prevalence is about 0.2%, and prevalence declines after adolescence, and there are many conduct disorders during adolescence. And adult use is strongly associated with suicidality. How about inhalant intoxication? Nystagmus, incoordination, again, lethargia, depressed reflexes, psychomotor retardation, tremor, muscle weakness, again, blurred vision, euphoria, stupor, coma. If two or more of the following signs, then we can speak about inhalant intoxication. Opiate-related disorders, prevalence is about 0.37% in adults. In particular, if there are the injection opioid users, there is the hepatitis A, B, and C risk plus HIV. Therefore, our injection users must be dealt with carefully. Problem behavior or psychological changes in case of opioid intoxication, especially there is the pupillary constriction, coma, speech impairment, and slurred speech and some attention, and opioid withdrawal. In opioid use disorder, we always check for the signs of withdrawal because sometimes you have to provide treatment during times of withdrawal, and therefore it's important to identify the symptoms of withdrawal and treat accordingly. Dysphoric mood, nausea, vomiting, especially nasal discharge, and pupillary dilatation, pyrorexia, diarrhea, yawning, fever, insomnia. As I told you, we treat accordingly. Last 5 minutes. Sedative, hypnotic, or anxiolytic related disorders, benzodiazepine, barbiturates, some sleeping medications, and the prescribed sleeping medications and antidepressants can be included. The prevalence is 0.3% among adolescents and 0.2% among adults. The females appear to be at a higher risk for prescription drug misuse of this class of substances. Can be detected in toxic rings for up to a week, and in particular at high doses can be lethal, especially when mixed with alcohol, the sedatives, hypnotics, and anxiolytics. Again, similarly, in intoxication, coordination and attention, nystagmus can be the case. In withdrawal, again, autonomic hyperactivity, tremor, insomnia, nausea and vomiting, hallucinations, anxiety, and seizures. And another important thing, stimulant use disorder, especially methamphetamine. Especially recently, it's a major issue. For cocaine use, the prevalence is 0.3%, especially childhood behavioral disorders and adult antisocial personality disorder are associated with use of stimulants. How about intoxication, tachycardia, bradycardia, pupillary dilatation, elevation or lowering of BP. Vomiting, nausea, weight loss, psychomotor change, muscular weakness, respiratory depression, chest pain, arrhythmia, confusion, seizures. So, it's quite commonly used. That's the reason why, in case of intoxication, it's very important to know about these symptoms and intervene accordingly. In withdrawal, most fatigue, insomnia or hypersomnia, increased appetite, psychomotor retardation, or agitation. Tobacco-related disorders. Well, initiation of smoking after age 21 is rare. People are saying I'm not smoking every single day, not a daily smoking, which is very prevalent recently. For tobacco-related disorders can lead to mood disorder, anxiety, personality disorders, and there are some other accompanying psychiatric disorders. Individuals with low incomes and low educational levels are more likely to initiate tobacco use and less likely to stop. With regards to tobacco, there is no intoxication in DSM-5. Other or unknown substance use disorders, as others, non-steroidal anti-inflammatory drugs, cortisol, anti-Parkinsonian medications, antihistamines, unknown, of course, when the substances is unknown. Also, it speaks about withdrawal and intoxication, very lastly, gambling disorder. As I told you, the other behavioral disorders are not yet included in the diagnostic criteria, but previously known as pathological gambling, and is under the category of impulse control disorders, but now defined as gambling disorders. Again, just like the other substances use disorders, the symptoms must last over a 12-month period and should lead to an impairment and loss of control in the daily life. It is 0.2, 0.3% in the general population. It is more in males. For females, less, but the progression is more rapid in women. And what is important is in those with gambling disorder diagnosis, there is a suicidal. About 17% of those commit suicide, so close follow-up is important. Also associated with other substance use disorders and impulse control disorders for males, and mood and anxiety disorders in females, which is pretty much associated with. Therefore, the psychiatric disorders, secondary in the accompanying gambling disorder, should at the same time be considered. Thank you for your attention.